Bravissimo, come lo ricordo.
Thank you.
Good morning. So we start this session of thesis dissertation for the International MD program. The first candidate is Sarah Suad Sheiban, who discusses a thesis entitled Clinical and Epidemiological Features of Myocardial Involvement in Patients with Idiopathic Inflammatory Myopathies, with Professor Emanuele Bosi, Professor Patrizia Rovere Querini, and Dr. Giordano Pietro Vitali. I would ask Professor Bosi to introduce the candidate and the topic of the discussion.
Yes, just very briefly. Good morning, everybody, and thanks to Sarah for being here today with us discussing this interesting topic, which deals with idiopathic inflammatory myopathies, which is a topic quite extensively investigated at San Raffaele by some group led by Professor Rovere Querini. And in this context, the specific topic of today's dissertation is led by you. I know that you worked very hard, and I'm asking you to present to the Commission the result of your work. Please, Sarah.
Thank you.
If you wish, you can stay without the mask.
Yes, please. Okay. Thank you, Professor, for your kind introduction, and good morning, everyone. So I will now present my thesis project, which is indeed on clinical and epidemiological features of myocardial involvement in patients with idiopathic inflammatory myopathy. Idiopathic inflammatory myopathies, or collectively referred to as myositis, are a heterogeneous group of rare autoimmune conditions that primarily affect the skeletal muscle. There are four major subtypes of myositis, which are predominantly distinguished on the basis of histological features, and that entail dermatomyositis, polymyositis, necrotizing autoimmune myopathy, and sporadic inclusion body myositis, which can be found either alone or, especially in the case of dermato and polymyositis, in association with other conditions, such as connective tissue disorders or neoplasms. The age of onset of myositis is primarily set at around 52 to 56 years old, and females are generally more affected than males, both in the fertile and non-fertile period. So as I said before, muscular manifestations are the core presentation of myositis. And despite there are some differences in terms of onset, distribution, and affected muscles or muscle groups, muscle weakness between the different subtypes, muscle weakness is the dominant symptom in all forms. But there are also extramuscular manifestations that can be frequently observed, especially in relation to dermato and polymyositis, which entail cutaneous abnormalities that are actually pathognomonic for dermatomyositis. An increased predisposition to develop some forms of cancer, upper GI and pulmonary manifestations, and last but not least, cardiovascular manifestations, which are the topic I would like to focus on today with my presentation. Cardiac events represent the second cause of mortality in the myositis population, albeit often remaining asymptomatic for extended periods of time. The major cause of cardiac death in this population is represented by congestive heart failure, but other causes of cardiac mortality have been recognized in myocardial infarction and fatal arrhythmias. The pathological mechanisms that are at the basis of the development of these complications are not yet clarified, but myocarditis is thought to be among them. So myocarditis is referred to as the inflammation of the myocardium. But despite this rather clear-cut definition, it is very difficult to recognize because of the different reasons. First of all, myocarditis is caused by a multitude of etiological agents, among which the infectious and autoimmune ones represent the most important, or at least the most common. This multitude of causative agents is also linked to different pathological mechanisms that lead to a variable distribution of inflammatory processes inside the myocardial tissue. And again, there are both focal, scattered, or diffuse forms of myocarditis. This microscopic heterogeneity is also reflected macroscopically by heterogeneous clinical presentation of the disease, which, however, in the majority of the cases, tends to remain asymptomatic. But there are also acute and chronic manifestations that are linked to myocarditis, and actually the acute ones usually tend to mimic the presentation of other more common cardiovascular conditions, among which acute coronary syndrome or congestive heart failure or supraventricular or ventricular arrhythmia. Instead, for what concerns the chronic manifestation, the most important, the one linked to the higher risk of mortality, is dilated cardiomyopathy, which derives from the perpetuation of the inflammatory process that leads to the progressive substitution of the cardiomyocytes with fibrotic tissue. So we can already start to recognize, to understand how challenging it really is to diagnose myocarditis. And indeed, of all the available instrumentation that we have nowadays for the investigation of the disease, only endomyocardial biopsy is able to unequivocally confirm the presence of myocardial inflammatory infiltrate and hence myocarditis. Indeed, among the biomarkers that are usually tested and usually elevated in the case of myocarditis, there are acute phase reactants, which, however, are not specific to the myocardial tissue, but rather are markers of an active ongoing inflammatory process somewhere in the body. And instead, on the other hand, cardiac troponins are specific for the myocardium, but they are not specific for myocarditis. Also, electrocardiographic alterations, like often remaining subtle and therefore undetected, are once again not specific when identified. And kinetic and volumetric abnormalities that can be usually observed at echocardiographic examination are once again not indicative for the condition. Instead, cardiac magnetic resonance imaging, which is a rather new tool using the investigation of myocarditis, holds an unparalleled potential for tissue characterization. It is therefore able to highlight the presence of edema and other markers of inflammation inside the tissue under investigation, so in this case, the myocardium. But despite this, it is still not able to give information about the etiology of myocarditis, which is a duty that is only reserved to endomyocardial biopsy, which is still considered to be the gold standard for the diagnosis of myocarditis, but is nowadays regarded to as a second-line examination because of the procedural risks that are associated to it, and is therefore seldom performed. So, for our project, we focused on the estimation of the prevalence of myocarditis in idiopathic inflammatory myopathies, and also on the characterization of myositis patients who developed secondary myocardial involvement, and in the identification of potential risk factors for myocarditis development in this specific population. In order to achieve this, we started from an initial population of 42 patients with an established diagnosis of myositis, and we looked for the presence of myocarditis in each of them. Inclusion criteria entails the elevation in the blood of cardiac troponins of both T and I isoform, because in the myocarditis population, troponin T may be re-expressed by the degenerating muscle fiber, and therefore leads to the diagnostic biopsy. And another parameter was the evidence of an inflammatory infiltrate at either cardiac, in the myocardium, of course, at either cardiac magnetic resonance imaging or, when present, endomyocardial biopsy. Through this, we identified 33 patients affected by myocarditis and 9 instead not presenting this complication. And we compared the two patient cohorts through a series of demographic, clinical, laboratory, and histological data, and we also performed some specific analysis on the myocarditis population, like the covariance matrix analysis and the progression-free pathway. So in accordance with the current literature, we observed that the majority of myocarditis patients suffer from dermatomyositis. But curiously, we also observed that all of the patients who had a diagnosis of necrotizing autoimmune myopathy also proceeded to develop this complication. Always in accordance with the current statements on the topic, we found that not only patients were completely asymptomatic for the disease, but they also did not show any abnormality at the electrocardiographic examination. So the disease, this manifestation was totally occult to them. Compared to the non-myocarditis patients, myocarditis individuals had more advanced biological age at myositis onset, and also presented elevated levels of both systemic and muscle-specific inflammatory indexes, which was also accompanied by a higher percentage of degenerative necrosis at skeletal muscle biopsy. And they also presented, always compared to the non-myocarditis patients, a lower muscle function, which was tested using the manual muscle testing scale, a tool used by the examining physician to assess indeed muscle strength by asking the patient to contract specific muscles or muscle groups against gravity and against an applied external resistance. At the covariance matrix analysis, we observed that there exists a direct relationship between the average cardiac troponin I levels in the blood and the age of onset of the primary condition, so of the myositis. And there is also an indirect relationship between the levels of the same biomarker and the mean manual muscle testing score. So this basically confirmed what we also observed in the comparison with non-myocarditis patients. But perhaps the most important finding of our project is related to the predictive variables for the development of myocarditis. Indeed, the biological age of myositis onset is the most important risk factor for the development of myocarditis in the myocarditis population. We observed that all of the patients who were diagnosed with a form of myositis when they were older than 53.7 years old proceeded to develop this complication. Instead, for patients younger than this age, the probability depended on the serum levels of the muscle-specific inflammatory indexes, such as aldostasis and CK, for which the risk was elevated by 3-fold and 5-fold respectively when the biomarkers exceeded the established value. So in conclusion, we observed that the prevalence of myocarditis in idiopathic inflammatory myopathy is remarkably high. In our population, it was set at 78.6%. We also observed that compared to the non-myocarditis population, myocarditis patients had a more advanced stage at the onset, at the outbreak of their primary condition, a more aggressive course of the disease, and also more pronounced muscle weakness. And we also observed that biological age and myositis onset and the serum levels of CK and aldostasis could help identifying patients at high risk for myocardial involvement, so they could help predict the risk of myocarditis. And this is important because yearly ECG screening is currently recommended to all newly diagnosed myositis patients, along with a detailed cardiological history. So by knowing that there are some patients who are more predisposed than others to develop this kind of complication, we could tailor the cardiological follow-up according to this risk, and therefore meaning that we could submit the high-risk category to more in-depth analysis with echocardiography and especially cardiac magnetic resonance imaging in order to proceed with the early identification of myocardial involvement from the myositis and intervene appropriately through the correct management in order to prevent the development of the secondary and deadly complications, such as the cardiomyopathy, congestive heart failure, and the fatal arrhythmia. So thank you all for your attention, and I'd like to thank my supervisor, Professor Bozzi, my co-supervisors, Professor Petrovere and Dr. Vitali, and I would also like to acknowledge the arithmology unit, the radiology unit, and neurology unit, and also the myositis and myocarditis clinic.
Thank you very much. Congratulations, this was a great dissertation, so I leave the word to Professor Bozzi to start the discussion.
Well, very clear presentation. Having heard you and thinking as a clinician, one of the most immediate questions is whether an early diagnosis of this kind of inflammatory cardiac diseases may in some way modify the approach in order to reduce the risk of further progression to cardiac failure.
Yes, of course. I mean, this is the aim of applicating the...
But by which specific therapeutic strategies can be?
Yes, of course. So I read a paper that said that if you, by modifying the therapy for the primary conditions of the myositis, it is possible to also modify the development of the complications, extramuscular complications that are linked to the disease. And in the case of cardiovascular involvement, they actually observed that this works. So by maybe potentiating the treatment of the primary condition, by adding some immunosuppressants to the corticosteroid therapy, it is possible. I think it could be possible to
modify the natural history.
I don't know if it could be possible to prevent the development of myocarditis, but it would definitely be possible to slow down the progression and
probably
prognosis.
Numbers are too small to imagine to organize controlled trials.
It's difficult to have.
And also it's quite heterogeneous, the population, so in view of any kind of clinical trial. Anyway, thank you, very interesting.
Thank you.
Professor. Professor Rovere Querini?
I'd like to know how your job could affect and be useful for the everyday medical practice.
It could be useful because, as we said, it could be. I think it could be really worth applying in the clinics because it could modify the prognosis of this patient. Because we found this data by retrospectively, so analyzing patients who already developed myocarditis. But now it could be useful to apply this model prospectively to understand if it really works and if it's really capable of modifying the prognosis. So probably by applying especially the regression tree, which are the core finding of our study, we could, maybe.
So you mean this is the first step of the steer?
Of what?
This is the first step of the steer.
Yeah.
Professor Manfredi?
Yeah. But in inflammatory myopathies, there is a long story about autoantibodies. Make sure that we have analyzed them carefully and probably did not find substantial association.
No.
I would just like to speculate a bit on this lack of association. Do you think that this specific involvement how is it related to acquired immunity? Do you think that this is something that is associated with specific recruitment of tissue damaging T cells? Do you think that actually in autoimmune diseases there are quite a lot of features that are associated to age, and we really do not understand that well at the role of immunosenescence, for example, in this overall story.
Sorry, you can hear very well.
Daniela Mascherini.
Exactly. So the issue is basically this is quite a widespread involvement, actually much more important possibly of what we have thought before. It's not associated apparently with specific subset of autoantibodies.
No.
So, but this is an autoimmune disease, so possibly this is caused by activation of autoimmune T cells in this case.
Yes.
There's a general issue, for example, in vasculitis about diseases in which age is actually quite relevant for the development of specific clones of tissue damaging autoimmune T cells. So the point is, do you think that immunosenescence can play a role in these patients? Do you think that this is something that increasing the age of your cohort will get more important? I mean, I understand perfectly that there is basically no evidence in the literature on this. So, but just wildly speculating about it.
Probably yes, it could be a possibility. You could try and see if there is some association with the immunosenescence, because we try to see if there were any association with autoantibodies. We look for the most common antibodies, especially in the case of dermatomyositis, which is the subtype that is associated to the production. But there wasn't any significant association. So probably there is another etiology that is not concerning the production of autoantibodies, probably concerns the T cells, because dermatomyositis itself is related to T cells, which then recruit B cells, which start producing antibodies, giving rise to other manifestations, and all the syndromes that we know are associated to dermatomyositis. But it's not the only way. So there could be any other possibility. We should try and understand better, of course, by analyzing specifically.
I have a question as well. So I think that the most important part is trying to predict myocardial involvement starting from the peripheral situations of striatal muscles. So the question is, did you check whether the severity of neurological involvement, meaning also electromyography, muscle biopsies, were a predictor of?
We analyzed muscle biopsies, and indeed we found that in the myocarditis population, there was all of the myocarditis patients had degenerative necrosis at muscle biopsy. Instead, for what concerns the non-myocarditis population, only 3 out of the 5 patients who actually underwent skeletal muscle biopsy presented it.
Yeah.
But I don't.
Electromyography, which is much easier?
No, we didn't look at electromyography. We looked at the NMT scale and
Stefano, from which we are reviewing all that is part of his specialty.
Future evolution.
Future evolution.
Okay, no other question? So since you responded also to Professor Manfredi's questions, we are prepared to give you also a degree in philosophy. So you can come back later.
Okay,
Thank you.
thank you. Thank you very much.
Era una battuta, non prendere.
Dicono che siamo
È stato breve.
Okay, so it was pretty fast because you were so great. So congratulations. I declare that the graduand Sarah Soad Sheiban has fulfilled all the requirements for the master's degree with the comprehensive final grade of 110 over 110 plus honors and special mention. And by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery. Congratulations.
Thank you.
Congratulations.
So the nicest part starts now. So you finish to study, now you have to work.
Yes.
So we wish you had enjoyed the period with us here at San Raffaele and hope you will come back as a postgraduate.
Thank you. Thank you all so much.
Cheers.
Thank you.
Sorry. I'm very old. Okay, cheers.
Thank you.
Yes.
Okay.
Dai seria.
This is the most difficult part. Okay, cheers.
Ciao, arrivederci.
Eh,
Una candidata che ha i genitori bloccati in autostrada.
Questa?
Quindi, è la seconda, Carrone. Quindi se per voi va bene andremo con Turano.
Turano c'è già?
Sì. Ok, grazie. Sì, passiamo al terzo perché oggi...
Ma neanche quando c'hanno i figli che si laureano si alzano dal letto. Questo mi crea una difficoltà incredibile, adesso laureo uno al posto dell'altro.
Cambierà questo, non è più ABC, diventa ACB.
Ma che bello.
Ma che bella!
È successo Margherita?
No, i genitori bloccati in autostrada e quindi modifichiamo il testo.
Chissà come stressato.
Can you go back? La prima diapositiva non è questa. Prego. Benissimo. You can sit down. You can take the mask off if you wish. Okay, so thank you very much for accepting to anticipate your dissertation. So we will be medical doctor a little bit earlier than expected. So we are going to discuss with Mr. Raffaele Turano a thesis entitled Brain Functional Connectivity Disruption in a Large Cohort of Patients with Primary Progressive Aphasia. He is discussing with myself and Professor Federica Agosta. So Raffaele did a great job in the last 2 years when he met us. This is an important topic because we are covering an issue which is related to many different neurodegenerative conditions in neurology. And this is a complex phenotypic presentation of some forms of degeneration and possibly dementia. And Raffaele is going to take some risk because he has audios and videos to show. So there might be some problems, especially with the storm outside. So good luck, my friend.
Thank you very much, Professor, for this introduction. I'm today going to speak about brain functional connectivity disruption in a large cohort of patients with primary progressive aphasia. First of all, let's define what is aphasia. Aphasia is considered a disorder of production and or comprehension of verbal messages that is usually due to focal lesion in the left hemisphere. This is particularly true for right-handed people, but also for a good 70% of left-handed people. Of course, we speak of a disease in people who previously acquired and used language normally, so we exclude all those conditions related to sensory, executive, or folk disturbances. The cognitive and language feature of aphasia have been well established by Gornot and Pini and colleagues in 2011, and they have a crucial role in the diagnosis of primary progressive aphasia, but also in the differential diagnosis between the 3 different phenotypes of PPA, which are the semantic variant, the non-fluent variant, and the logopenic variant. Speaking about the semantic variant, the main cognitive features are anomia, impaired object knowledge, especially for low frequency and low familiarity items, and impaired single word comprehension. In the diagnostic process, the cognitive features are supported by neuroimaging, where we can find a direct damage in the left anterior temporal lobe, with a specific pattern atrophy with conventional MRI or with hypometabolism and hypoperfusion assessed with factor stack. The anomia can be highlighted with different tasks. One of these is, for example, the naming task, where the patient is asked to name items, and here I report an example of an Italian-speaking patient.
Quella bistecca? No. Che io la mangio anch'io sempre questa che mi piace. Questo qua in piedi così non l'ho mai visto io.
About the non-fluent variant PPA, here the main cognitive features are agrammatism and forceful speech, with inconsistent speech sound errors and distortion that are commonly referred to as speech apraxia. And even here, the cognitive features are supported with neuroimaging, where we can find a direct damage in the left inferior frontal gyrus and within the insula. Here, for the patient, the task was to describe the picture it sees, and the difficulty in spontaneous speech in this patient is that they cannot build sentences, and you can hear the example.
La pianta, la gara sul tappeto.
The variant is the logopenic variant, which is characterized by impaired word retrieval and impaired repetition. And in this case, neuroimages show direct damage in the left temporal parietal regions. And here, for the repetition task for this patient is very difficult, especially when they have to repeat long sentences.
La piccola parla già.
La piccola parla già.
Mi ha promesso di passare oggi stesso.
Mi ha promesso che viene oggi stesso.
Lui non è affatto facile da accontentare.
Lui non è facile da accantarlo.
important to say that from a pathological point of view, there is no direct correlation between the preclinical variants and the type of neuropathological substrate that is behind it. As you can see here, from a study published 2 years ago from our lab, the semantic variant is mostly characterized by a TDP43 type of neuropathological substrate, whereas the non-fluent variant is mostly characterized by a FTCL type neuropathological substrate. And this highlights the fact that these two clinical variants share a common frontotemporal lobar degeneration. On the other hand, the logopenic variant is characterized by an Alzheimer's disease type of neuropathological substrate. So the rationale behind our study is that this preclinical presentation of primary progressive aphasia reflects heterogeneous neuropathological substrates that are difficult to be recognized in vivo. We know that a multimodal approach that combines structural MRI and cognitive information is very useful in distinguishing these variants. And we know that resting state functional MRI is promising in the investigation of human brain network and brain functional connectivity alteration within and behind the language networks. It's also important to say that due to the rarity of this disease, the actual literature is based on a small sample that's limiting the generalization of findings. The aim of our study was to assess the resting state functional connectivity pattern associated with each of the 3 variants of PPA, using a large cohort of patients that was recruited from different clinical centers, here in the north of Italy, including the institution San Raffaele, as well as in Belgrade, Serbia. And all our patients underwent a neurologic and a neuropsychological assessment, including a full language factory. They also underwent magnetic resonance imaging, including specifically structural MRI and resting state functional MRI. And then data were analyzed first on a single subject level in order to extract the network of interest, that then were averaged and compared among individuals. And here I report a table of the main clinical and demographic characteristics of our sample. We enrolled 14 non-fluent variant J, 22 logopenic variant, and 28 semantic variant, and we compared them with 62 healthy controls. As you can see from this table, our sample was matched in terms of age, sex, disease duration, as well as disease severity, as it is expressed by the clinical dimension rate total score. It's important to say that in support of our diagnosis, in the CSF examination, the ratio between phospho-tau and amyloid beta 42 was consistently higher in logopenic variant respect to the other 2 clinical variants, as it is observed in Alzheimer's disease. Speaking more in detail about our MRI processing of data, we study functional connectivity first on a single subject level, and using a 3 Tesla machine here in San Raffaele Hospital and a 1.5 Tesla machine in the Clinic of Neurology of Belgrade. Then using dependent component analysis, we were able to extract the network of interest and to build a 4D image for all subjects and for each network. Then we performed ANCOVA models using biological parametric mapping in order to test the resting state functional connectivity alteration between our 4 groups, taking in consideration a voxel-wise correction for gray matter atrophy and the fact that the images were taken using 2 different scanners. And here, going to the result, on the left, on cyan color, you can see the network of interest, whereas in shades from red to yellow, you can see the alteration in functional connectivity. And you can see that all PPA, when compared to healthy controls, showed a reduction in functional connectivity in the posterior cingulum, the precuneus, as well as the left inferior parietal region. Whereas the logopenic variant, when compared to the other 2 clinical variants, the semantic and the non-fluent, showed an increased functional connectivity in right inferior parietal regions. For what concerns the cerebellar network, the non-fluent variant and the semantic variant, when compared to healthy controls, showed a reduction in functional connectivity in areas within the cerebellum that are more correlated with cognitive function rather than the motor function, whereas the logopenic variant, when compared to healthy control, showed a reduction in the left caudate, show an increased functional connectivity in the left caudate. Speaking about the salience network, the non-fluent variant, the semantic variant, when compared to healthy control, showed a reduction in functional connectivity in the middle cingulum and bilateral insula. The non-fluent variant, when compared to semantic variant, showed also a reduction in functional connectivity in the orbitofrontal regions. The logopenic variant, when compared to the all the groups, including healthy controls, showed an increased functional connectivity in more anterior region. For what concerns the frontostriatal network, the non-fluent variant and the semantic variant, when compared to healthy control, showed a reduction in functional connectivity in the anterior cingulum, whereas the logopenic variant, when compared to the other two clinical variants, showed an increase in functional connectivity in the same region. Last but not least, the left frontoparietal network, we can see that the non-fluent variant, the semantic variant, when compared to healthy control, showed a reduction in functional connectivity in left, superior frontal, and inferior parietal regions. Whereas the logopenic variant, when compared to the other two clinical variants on the left hemisphere, show an increase in functional connectivity in the same region. But when we take in consideration the right hemisphere, we actually see that the logopenic variant showed a decrease in functional connectivity with respect to the other two clinical variants. And to conclude, we can say that the three PPA variants share a common pattern of functional connectivity within the default mode network, suggesting that this network is affected in PPA regardless of the underlying pathology. The non-fluent variant and the semantic variant share common alteration within the cerebellar network, a region that are known to be involved in eye cognitive function and that are functionally connected with frontal area. Frontal and frontoparietal networks, and this is not surprising because it reflects the common frontotemporal lobar degeneration. On the other hand, the logopenic variant, when compared to the other two variants, showed an increased connectivity in more anterior region within the salience and the frontostriatal network, as it observed in Alzheimer's disease. If this increasing connectivity in areas of the brain that are initially spared from the disease is a compensatory mechanism, we don't know. This needs to be further investigated, but we can conclude saying that resting state functional MRI is a powerful method to improve in vivo distinction between these clinical variants. And I would like to thank Professor Massimo Filippi and Dr. Federica Costa for this opportunity, all the group of neurodegenerative disease group. Also, thank you very much for your kind attention.
Thank you very much, Raffaele. I think this was a very important dissertation because you were able to manage with a complex field of clinical neurology, which is aphasia, collecting a large sample of people with these rather rare conditions. And you also managed to study all of them with advanced technology related to MRI. So my question to start the discussion is pretty straightforward, and it is so since, as you showed at the beginning, we are pretty able to distinguish the different phenotypes of PPA based on neuropsychological assessment and atrophy on conventional MR. Which is the role? Which do you think is the role of resting state functional MRI in the clinics? I mean, not for dissertations.
Thank you very much for this question. That's true. In theory, cognitive features as well as neuroimaging are often enough for the diagnosis, but in clinical practice, sometimes the diagnosis is not so easy, especially in the early phase of the disease, when the cognitive features I mentioned, maybe the patient only show one of the cognitive features I mentioned that is not enough for the diagnosis, or also when the neuroimage, the atrophy is not so prominent, because we know also with other neurological conditions that resting state functional MRI alterations precede the actual neuronal loss, so the actual loss of parenchyma. And so I think that in early phases of the disease can be very useful in distinguishing these variants. And also another important, it's also very important in cases that are less common but have been reported in literature, that are the mixed aphasias, in which there is no clear pattern of atrophy and the cognitive features are not so clear to give a diagnosis that is straightforward. So I think in this case it can be very useful.
Okay, thank you very much. I guess that Professor Agosta has something to ask you, if I know her.
Yes. First of all, let me congratulate you, Raffaele. You did a great job, and I also congratulate for your motivation and passion in our collaboration. So my question is very specific. So you show a divergent pattern with the decrease and increase connectivity changes in these patients. But one could expect just decreased connectivity because of the amount of structural damage we observe in these patients. Which is the possible interpretation of increased functional connectivity?
Thank you very much for this question. Yeah, I think it's very fascinating and interesting because when I first approached the study, my idea was we are speaking about a neurodegenerative disease, so with the loss of parenchyma and the loss of neurons, I expect accompanying a reduction in functional connectivity. So to see that there are areas that actually have an increased functional connectivity is very interesting. And I think there are two main hypotheses for this. The first hypothesis is that this could be a compensatory mechanism. We have to do a consideration that all the patients that were enrolled in our study was at an early phase of the disease. So maybe in early phases of the disease, because of the loss of parenchyma in the left hemisphere, the right hemisphere and the areas that survive try to compensate the loss of this damage. On the other hand, it could be another hypothesis could be that this increase in functional connectivity is intrinsic to the disease, meaning that when we have the damage in the left hemisphere, because we lose also the connection between the two hemispheres, so we lose also the inhibitory connection that comes from the left hemisphere. This could be that we have this paradoxical increase in functional connectivity. Of course, it's a fascinating thing, and I think that this could be also studied with longitudinal studies in which we can assess if this increase in functional connectivity is related also in better performance in cognitive tasks, for example, and this could be in support of our first hypothesis, or if this increase in connectivity is not followed by better performance, and so maybe it's intrinsic of the pathology, but this needs to be further studied and investigated.
Thank you. Any other question? Comments? So if not, thank you very much. So you can come back in 2 minutes.
Invece ce la vuoi proprio raccontare invece.
Poi la togliamo per la foto. No? So congratulations, you did great, the last bit of your career, and so I declare that the graduate Raffaele Turano has fulfilled all the requirements for the master's degree with the comprehensive final grade of 103 out of 110, and by virtue of the authority vested in me by the Italian law, I confer him the master's degree in medicine and surgery. Congratulations. So we really appreciated you stayed with us for 6 years in the university, and with us 2 years in the lab and the neurological clinics. So we do hope that you will have a good career in the future, and you pass the examinations for the postgraduate in neurology if you still think to become a neurologist, and we will be very pleased to have you again back in the near future. So congrats, Professor. This is for you. You have to look at him. Perhaps you can take the mask off if you wish. So you have proofs for all. Okay.
For the future that is the end.
Okay. Okay.
E quindi niente da dire.
Ma lei quante volte si è già laureata in questa sessione?
Un mese che si lascia.
Se vuole...
Le lascio, sì.
Ah, okay. Quindi adesso anni chiarico, se per voi...
Anni in chiarico.
Va bene.
Ok.
Possiamo?
Assolutamente. Ma che cazzo si dice questa roba qua? Come cazzo dico questa roba qua?
Devi chiedere a loro. Devi chiedere a lei.
Buongiorno. Okay, if you wish, you can take the mask off, so it's much easier. You don't risk too much. Okay, so we go ahead with the next dissertation, which is given by Rebecca Anni Chiarico. She's going to discuss a thesis with Professor Paolo Manunta and Dr. Chiara Livia Lanzani. I leave to the supervisor and the assistant supervisors to read the title of the thesis because it's well beyond the aphasic capacities of the president. Thank you very much.
Rebecca will discuss the role of gene polymorphism in Cloto and FLG-NC1 gene in the development of kidney damage in hypertensive patients. So Rebecca did a good job with us in patient clinic, and she decided to go more in deep the relationship between kidney damage, hypertension, and genetic polymorphism. Please, Rebecca, can you explain our work?
Hypertension is a condition affecting 26% of the world population. However, despite this very big prevalence, blood pressure control is achieved only by 30% of the hypertensive population. The blood pressure values below 140 over 90 millimeters of mercury as suggested by the guidelines. Hypertension is also the major modified risk factor for both cardiovascular and neurological diseases, as well as renal damage in 27% of the cases. In particular, renal damage is observed through the presence of microalbuminuria in 10% of the hypertensive population, and through a decline in the glomerular filtration rate, which is much higher than the physiological age-related decline of 1 ml per minute per year. Essential hypertension results from the interaction of both environmental and genetic factors. In particular, genetics seem to play a role in the increase of transport and reabsorption of sodium at the level of the visceral convoluted tubule of the kidney, as well as in the increase in vascular resistance in absence of renal injury. And for this purpose, the aim of our study was to understand the polymorphisms among two of the genes candidate for hypertension, in this case the clotho gene and the SLC81 gene, contribute to renal damage in the population of hypertensive patients. This is the SNP we selected for the clotho gene. It is a miscentration of the exon 2 of the clotho gene, causing an amino acidic change from a phenylalanine to a valine. It also causes lower level of circulating clotho-protein, and the recent literature has also evidenced the association between the G allele of this SNP and salt sensitivity, leading to renal insufficiency and organ damage. For the SLC81 gene, we selected this particular polymorphism, which is an intransnic for a sodium-calcium exchange hormone, NCX1, which is a transmembrane protein that channels ions of sodium and calcium in opposite direction across the membrane, according to an electrochemical gradient. And for this reason, it also participates in the calcium cellular homeostasis. Its role in the excitation-contraction coupling makes it a good regulator also of the vessel myogenic tone through increase in cytoplasmic calcium concentration. And literature has also evidenced an association between the AA variant of this particular SNP and nephritis. In our study, all of our patients were followed up correctly, and the yearly annual visits guaranteed the treatment homogeneity among all of them. In the first visit, we evaluated the blood pressure values, and after a physical examination, we considered the introduction of an antihypertensive therapy. Then on annual follow-up visits, besides blood pressure control, we also checked the renal function by observing the presence of microalbuminuria and by checking the creatinine values, to which we then calculated the estimated glomerular filtration rate. Then after evaluation of blood pressure values, we considered the adjustment of the antihypertensive therapy. In this study, we considered that the renal damage decline in the kidney function is twice the expected rate in the general population, hypertensive population, through onset of microalbuminuria or through the presence of polycytes. Our population was composed of 406 patients. All of these patients were upon their first finding of essential hypertension, and therefore none of these patients was in treatment with antihypertensive therapies prior to the enrollment in our study. They had a mean age of 43 years and a BMI of 25. These essential hypertensive patients started off with mean baseline values of blood pressure of 148 over 94 millimeters of mercury and a baseline eGFR of 99 millimeters per minute. By the end of the observation, we noticed an improvement in both diastolic and systolic blood pressure values, and in particular, blood pressure control was achieved in 64% of our population. This improvement is definitely attributable to the introduction of the antihypertensive therapy. As a reminder, these patients were on their first finding of hypertension, and therefore none of them was taking any sort of antihypertensive drug prior to this. The majority of them was under only one class of antihypertensive drug, for the most part ACE inhibitors or ARBs. However, there is also a big piece of them, almost 19%, which was still under no therapy. Despite this control, we still noticed a degree of decline in renal function in some of our patients. In particular, accelerated renal function decline was observed in 37% of our patients, with a median time to event of 12 years. Also, microalbuminuria occurred in only 7% of our population, and with a median time to event of 5 years. And this small number of cases definitely affected the significance of the genetic analysis for microalbuminuria. Blood pressure values were also analyzed according to genotype. Here, for clotho patients, we see for all the clotho variants an improvement in blood pressure values from the beginning to the end of the observation. And in particular, blood pressure control was achieved by 66% of our patients. And we also observed a significant association between these variants and the blood pressure values at the beginning of the observation, implying a possible role of the SNP at the beginning of the hypertensive history. Pressure values were also evaluated for the NCX patients. Also here we see an improvement from the beginning to the end of the observation, with blood pressure control achieved by 65% of our population, and a significant association was found between NCX patients, in particular those carrying the AG and GG variant, and the mean number of drugs taken by the patient at the end of the observation, implying the role of this SNP in the blood pressure values. GFR values were also evaluated. For cloto patients, we still see a degree of decline, and as a reminder, the G-ALID is associated to salt sensitivity, therefore increased risk of developing hypertensive, salt-sensitive hypertension. And in fact, here, patients carrying the GG variant had the highest rate of kidney function decline, seen as the slow eGFR. However, GT patients seem to start off with lower kidney function values with respect to patients carrying the other variants, but at the end of the observation and after the introduction of the antihypertensive therapy, their kidney function decline seems to slow down, implying that possibly the introduction of antihypertensive therapy may be beneficial in this type of patients carrying this type of variant. The same cannot be said for NCX patients, in which, despite the good blood pressure control and despite the introduction of therapy, we still see kidney function decline. This may probably imply the possible mechanism of this polymorphism in affecting kidney function through mechanisms that go beyond the simple blood pressure control. We also continued our analysis on the study of urinary podocytes, and preliminary results showed the presence of urinary podocytes in 12 hypertensive patients. Normally, podocytes are not found in the urine of patients with a healthy status, so this may be a possible early sign of glomerular damage. In conclusion, despite the good blood pressure control, we still see that essential hypertensive patients experience a kidney function decline. For the cloto patients, we have seen a possible influence of this SNP at the beginning of the hypertensive history. However, after the introduction of the antihypertensive therapy, this patient seems to improve, possibly implying the benefit that this patient carrying this particular variant take after the introduction of therapy. Instead, NCX patients continued to decline even after the introduction of the adequate therapy and despite the blood pressure control. Therefore, this may imply the possible role of this polymorphism in the decline in the kidney function through mechanisms that do not strictly depend on the control of blood pressure, but possibly can occur through the regulation of myogenic tone. For what concerns the podocyte study, we successfully proved the presence of urinary podocytes in hypertensive patients, even though the majority of these were dead or fragmented. And this may possibly imply this may possibly be seen as a sign of early hypertensive glomerular damage. During our study, we also encountered some limitations. For example, despite the very good blood pressure control we have achieved, we still don't know how long these patients have been hypertensive prior to the enrollment in our study. And therefore, we don't know whether this may have affected at some point the significance of our results. Also, the reduced number of microalbuminuria cases occurred in our population definitely affected the significance of our genetic analysis of microalbuminuria. However, this can also be the result of the very good blood pressure control achieved, and also the fact that almost all of these patients were in therapy with ACE inhibitors. For what concerns the podocytic count, instead, this procedure is still not standardized, and therefore highly operator dependent and time consuming. And this is definitely a young point. And today, the inconsistent role of microalbuminuria as an early sensitive marker for renal damage has opened the doors to new and future research, especially on the role of urinary podocytes as possible early predictors of hypertensive glomerular damage. The advantage of having a reliable early predictor that can anticipate future renal damage can help us in slowing down the future decline through through the adoption of preventive measures as well as studying tailored therapies according to the specific type of patients. And for this reason, this field is still widely open to research.
Thank you very much, Rebecca. This was a great talk and presentation. So I leave the podium to Professor Manunta or Dr. Lanzani to start the discussion.
Congratulations, Rebecca. What do you think is the role of curriculum in
Well, it is a regulator of, in this case, we have seen it as a regulator of the Western myogenic tone. However, it's very important also to guarantee the calcium balance and therefore, besides calcium, all the other ions, in particular sodium, because it is an anticortex agent for these two ions.
Okay, and so congratulations for your presentation, Rebecca. Do you think this kind of study may be useful in clinic, or is just an exercise that we have done for a dissertation?
No, I think that it could be useful, especially the results we have obtained for the genetic analysis. In fact, before concluding my presentation, I talked about preventing further decline. This is because we know that being positive or being a carrier of certain SNPs and certain polymorphisms definitely predisposes to the development of an early damage. And in people that we know are carriers, patients we know are carriers for these particular polymorphisms, we can anticipate the damage because we know that they eventually are going to develop the disease. Also, for the study of new therapies, we know that some patients carrying particular polymorphisms, for example, the NCX patients, as we have seen in this study, the therapy may be different, the response to therapy may be different for them according with respect to the clot patients, because also the kind of damage is different from the one that occurs in clot patients.
Any other question? Yeah, Professor Manfredi.
I share with Paolo Manunta a keen interest in clot. I was wondering, well, genetic polymorphisms are quite important, but probably are not the only determinant of clot action in such a complex setting. Do you think that, for example, to assess the blood concentration of the molecule could help better stratify your patients, or would be just a loss of money, also expensive?
No, I think it could be useful. In fact, some studies, even recent studies, have proved that patients with chronic kidney disease also have a reduced amount of circulating proteins. And by calculating the amount of circulating protoprotein, we can use this as a predictor of the patients that eventually are going to develop chronic kidney disease.
Any other question? Comments? No? So you can restore your blood pressure and come back in 10 minutes. Potete lasciare l'aula, grazie.
fai venire senza che abbiano ripetuto.
No.
Sì, ma...
Non correremo mai queste rischi.
Okay, so congratulations. You did very well. And I declare that the graduate Rebecca Annichiarico has fulfilled all the requirements for the master's degree with the comprehensive final grade of 106 out of 110. And by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery. Congratulations again. We really appreciated your dissertation and discussion, and you did a very good job also throughout the time you spent in this university. So myself and all the commission wish you all the best for your future career. So now you need to take this. You can take this off. This is very important to remind you of our university. Okay, you have to look at that.
Smile.
Okay, smile. The last bit, which is very complex. Okay. Congratulations again.
È arrivata.
Valentina?
Numero 2.
È arrivata? Questa? Sì, sì, perché poi abbiamo i collegamenti web. Dov'è che è? No, dov'è che è i miei foglietti? Faccio casino. Sì, volevo... Dov'è il nome della ragazza?
Margherita.
Good morning. So, good morning. I think we didn't need really to discuss your thesis because your results are impressive, but so you created a little bit of suspense by waiting a little bit. Otherwise, there was no entertainment with this thesis. So the thesis is discussed by Margherita Scarrone with Professor Patrizia Rovere-Querini and as assistant supervisor Dr. Valentina Canti and Dr. Federica Pasi. The title is A Multidisciplinary Approach to Recurrent Pregnancy Loss and the Repeated Implantation Failure Effects on Reproductive Outcomes. So, Professor Rovere-Querini, you...
I'm quite happy that she arrived at the end. I was a bit scared. So the thesis is really a joint effort between us and gynecologists. For this reason, we have both Valentina and Federica now that work as assistant supervisors, because after many years of pregnancy loss clinic, now we are starting to really review also our strategies for repeated implantation failure, how we at the San Raffaele. It's a condition that often is managed only by gynecologists, but we think that immunologists have many things to say on this topic, and so we started together a dedicated clinic, of which Valentina and Federica are the part, and also Margherita, who contributed really to the initiation of this clinic together, and so she will introduce the first data we collected during this year and a half.
Thank you very much.
I can also take the quiz. Can I?
Yeah. Good morning, everyone. Our work focused on a multidisciplinary approach to recurrent pregnancy loss and repeated implantation failure, and we focus on the effects of this multidisciplinary approach on the reproductive outcomes of our patients. First of all, what is recurrent pregnancy loss? Actually, there is no consensus in its definition, and it can be defined as either 2 or 3 pregnancy losses, which can be consecutive or non-consecutive. The estimated prevalence of this condition varies from 2 to 5%, depending if we consider 3 or 2 miscarriages. And actually, the observed frequency, the observed prevalence is higher than what you would expect to observe in case of sporadic miscarriages. And this means that there are some underlying conditions that predispose a woman to develop recurrent pregnancy loss. Repeat implantation failure instead is a concept that occurs only in the setting of reproductive technology, and it is defined as either 2 or 3 embryo transfers without further evidence of pregnancy. And its estimated prevalence is around 50%, but some authors have recently suggested that this could be an overestimation of the issue. Regarding the etiology, both recurrent pregnancy loss and RIP have a complex and multifactorial etiology, and the classical theory states that recurrent pregnancy loss is caused by a series of subclinical disorders that do not cause any medical condition to the woman, but when summed together, they can converge on an already fragile early pregnancy state, leading to abortion. And we used this model of the Jenga game because every block of the tower is a subclinical disorder. And when you remove enough blocks, you can cause the tower to collapse, which is the abortion. But what are the blocks of this tower? There are many proposed etiologic factors to recurrent pregnancy loss. The most important one in terms of frequency are the chromosomal abnormalities, but as the number of miscarriages increases, the probability of having chromosomal abnormality decreases, meaning that there are some other conditions. One of these conditions is the antiphospholipid syndrome, which has been causally linked to miscarriage. Then we have other proposed factors such as the immune factors, endocrine factors, including hypothyroidism and insulin resistance. And then some new proposed mechanisms include chronic endometritis, which is an asymptomatic inflammation of the endometrium that can cause reproductive failure. Then there are other causes such as male factor and uterine anomalies. However, when all known and potential causes for recurrent pregnancy loss are accounted for, almost half of patients will remain without a diagnosis, and we call these patients unexplained recurrent pregnancy loss. And this distinction is fundamental for our therapeutic strategy, because in case of explained LPL, we can prescribe candidate-specific treatments, for example, levothyroxine for hypothyroidism, low-dose aspirin and the molecular weight heparin for the antiphospholipid syndrome, or surgical correction of uterine malformations. Instead, in case of unexplained LPL, we usually prescribe empiric treatments, but this is a new field and it is a highly debated area. These empiric treatments may include progesterone and vitamin D, which have an immunomodulatory action. And then we have low-dose aspirin, which is prescribed empirically in women older than 35 years old. Then other possible immunomodulatory treatments, such as intravenous immunoglobulins or corticosteroids. And lastly, low molecular weight heparin, which will be the focus of our analysis today. And actually, heparin is a really interesting drug because it has many pleiotropic effects beyond its anticoagulation properties. And the main effects that are fundamental in this setting are the immunomodulatory and anti-inflammatory action, because heparin is able to inhibit the function of neutrophils because it can block the release of net and cytotoxic granules. It also can inhibit complement activation, and in the setting of antiphospholipid syndrome, it can inhibit the binding of antiphospholipid antibodies to their target, and in this way it increases the trophoblast migration and thus the implantation of the embryo. The aim of our study was to analyze the 3-year activity of the recurrent pregnancy loss outpatient clinic here in San Raffaele Hospital, and we focused on patient characteristics, the various investigations and treatments that we performed, the reproductive outcomes, and in the end of our analysis, we compared our unexplained LPL patients with patients affected by antiphospholipid syndrome and hereditary thrombophilia, followed at the Pregnancy at Risk Outpatient Clinic, another clinic here in San Raffaele Hospital. So, first of all, our patients were stratified based on the reason for first encounter into 184 recurrent pregnancy loss patients and 74 RIP patients. The first step is their diagnostic workup, including a thorough past medical history and past obstetric history. Then we prescribed first-level investigations, which included cardiac analysis and laboratory tests to screen for endocrine anomalies, autoimmune dysfunctions, and thrombophilias. If all these tests resulted negative, we then prescribed second-level investigations, which included diagnostic hysteroscopy and the chronic endometritis workup. Depending on the results of these two-level investigations, we prescribe either a specific therapy or an empiric therapy. Regarding the laboratory tests, it was interesting to find that actually the two groups, so the LPL and the RIP populations, which seem opposite in their pathogenesis, instead share many etiological factors, because they had a similar prevalence of hereditary thrombophilia, autoantibodies, endocrine dysfunctions, and chronic endometritis. The only two differences were encountered in the prevalence of antiphospholipid, which were more prevalent in the LPL group, but still also the RIP population had a higher prevalence of antiphospholipids with respect to the general population, meaning that also antiphospholipids could contribute to the pathogenesis of repeated implantation failure. And the other difference was encountered in the prevalence of male factor, because it was more prevalent in the RIP population. Regarding our reproductive outcomes, out of the 74 RIP patients visited in our clinic, 35 underwent at least one embryo transfer, and 16 had a clinical pregnancy. Thus, our clinical pregnancy rate was 46%, which is extremely high in this kind of patients. Instead, in the LPL group, we had 76 patients that remained pregnant during the follow-up period, and 26 had an abortion, with an abortion rate of 34%, which is in line, which is coherent with the literature for this kind of patients. We analyzed the possible effect of the empiric of the treatment, and we compared the patients with a favorable outcome and the patients with adverse outcome. Our favorable outcome was the detection of a clinical pregnancy in the RIP population and a viable pregnancy past 24 weeks of gestation in the LPL population. And comparing the two groups, we didn't find any significant difference in terms of demographic characteristics, prevalence of thrombophilia, and autoimmunity. The only difference was found in the rate of low molecular weight heparin used, because patients with a favorable outcome used more low molecular weight heparin than patients with an adverse outcome. Thus, this is a graphical representation of the effect of heparin in both groups, and as you can see, heparin was able to significantly reduce the abortion rate in the recurrent pregnancy loss population, and it significantly increased the implantation rate in the RIP population. Then we performed a multivariate analysis to account for the possible effect of confounders. And we actually found out that the molecular weight heparin remained effective in decreasing abortion rate and increasing implantation rate, notwithstanding the presence of thrombophilia. And this is a very important finding, because it means that we could also use heparin empirically in unexplained patients. And furthermore, when we stratified the patients based on their BMI, overweight patients with a BMI more than 25 actually lost the effect of heparin. And this could be due to an underdosage issue, because we use the prophylactic dosage, which is standardized and not adjusted to body weight. And thus, in this patient, it didn't have a statistical effect. Then we perform a multivariate analysis, including only unexplained FPL patients, and heparin remains significant, confirming our results. Furthermore, it is interesting to notice that the number of previous miscarriages does not influence the outcome of the pregnancy, and thus it seems reasonable to prescribe the molecular weight heparin used after the second abortion and not to wait until the third abortion. In the end of our analysis, we did a comparison between our unexplained LPL patients with antiphospholipid syndrome patients and hereditary thrombophilia patients. And what we found is that there was a significant difference within the unexplained LPL group between those that use heparin and those who didn't, and this confirmed that. But more interestingly, the three groups did not significantly differ. And this would point towards some shared pathogenetic mechanisms between the three groups, which means that actually we call those patients unexplained, but it's just because our diagnostic methods are currently not enough to diagnose some underlying conditions. And in conclusion, our study demonstrated the necessity of a dedicated multidisciplinary unit to the current reproductive failure because we had excellent reproductive outcomes, and we recommend to visit both Vita and FPL patients in the same unit because we have shown that they share many etiological factors and they also respond to the same therapeutic strategy. And in the end, we showed that heparin could really increase the reproductive outcomes of these patients, also in case of unexplained patients. Ringrazio tutto l'ambulatorio di Paragorbità e il centro di scienze per il supporto.
Thank you, Margherita. Very excellent. I didn't catch the last bit in Italian, but I think that Professor Rovere Guarini would like to start the discussion.
Yes, of course. Yes, I think that this data are really very interesting because despite now the common availability of multidisciplinary clinic, for example, pregnancy loss, for recurrent implantation failure, I think we are quite a new experience, and I think that the experience was really successful. So, strange, why do you think we have so many factors in common? How we can explain this? For me, it was really impressive. I didn't thought to find so many patients with the same underlying condition that we were really managing in the program.
I think we can consider both WIP and FPL as a spectrum of reproductive failure, where we have at the extremes recurrent pregnancy loss and repeated implantation failure. But they are actually two manifestations of the same pathology.
But this is unique as a point of view.
Yeah, because usually they are seen as two different pathologies and two opposite pathogenetic mechanisms, because one includes the implantation process and the other one is way beyond the implantation process.
Possibly they have something in common.
Dr. Canti or Dr. Pasi or together?
Thank you for the excellent work that you have conducted. Can you show us some data on non-conventional antiphospholipid antibodies in order to increase the rate of obstetric antiphospholipid antibody syndrome, condition in which it is mandatory to use logloglastrin and lomuletin?
Yeah, actually, in our patients, we tested for a non-covalent phospholipid antibody, which was the antiphospholipid complex, and we found a high prevalence of this antibody also in unexplained patients. It was around 15%. And this means that there are many non-covalent phospholipids that we could look for in the unexplained patients. And this is really important because if you were to include other antiphospholipid antibodies in the diagnostic criteria of the syndrome, we could extend the application of the molecular heparin also to these patients. And this would really
Congratulations for the work. You said it in your discussion, but I'd like to investigate a little more. You know there are two randomized trials that say that heparin doesn't work in unexplained recurrent pregnancy loss or repeated implantation failure. Why do you think we have such difficult results?
Yeah, I read those articles. They're really big, but actually, if you look at their population of the study, they have a mean BMI of 26 in both studies. And this means that the majority of patients are overweight. And they used standardized prophylactic dose. And this means that they could be underdosed. Yeah, so it would be interesting to reanalyze those data only in the subgroup of patients with a BMI less than 75, and we actually wanted to ask them.
And the workup of this patient was of the two papers of the trial. The workup was done really precisely.
They wrote that they excluded all endocrine autoimmune from the clinical conditions, so I hope so. Yeah.
Actually, in the Dutch one, they used the 0.3.
Yeah.
Underdose.
Yeah.
Really underdose. 2,800 units. That's very much.
26 of BMI.
Yeah, and I recently read a study where they analyzed the activity of factor 10 to understand the effect of heparin, and actually in overweight patients, it was in all cases underdosed.
But in this case, to ask a post-hoc analysis stratified according to the BMI, if these are big trials, it should not be possible.
We will try.
You can ask.
Yeah, we wanted to write a letter. We would like to ask because it's really important for these patients because it can really change their prognosis.
Okay, there is another question from Dr. Lanzani.
One more question. Did you check also the effect of blood pressure level in this question?
Yeah. When we collected the medical history and the receptive history, we also checked for the weight and the blood pressure. And we actually found a really high prevalence of hypertension.
Okay. We send that to you.
A lot of them.
You are our consultant, Chiara. They can do
The effect in the motivated analysis of the blood pressure level.
Because we didn't have a complete record of the data, so it wasn't possible to do a complete analysis. So, yeah.
I don't see any other questions, so thank you very much. Be ready very quickly because I don't think there will be much of a discussion.
Sì, certo. Me la salvo io per ragioni fotografiche.
Okay, congratulations and apologies because we are not recognizing all your value with what I'm going to say in a moment. So I declare that the graduate Margherita Scarrone has fulfilled all the requirements for the master's degree with a comprehensive final grade of 110 over 110 plus honors and special mention. And by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery. Congratulations. So your career was really outstanding and you did a great presentation today. So, I mean, we were really embarrassed because we don't have enough to give you. We have to take something back in order to graduate you. And so I guess you will have a brilliant career in the next future. And of course, since you have clearly a beautiful brain, I would suggest you to come back as a neurologist. Okay, so congratulations again. This is for you to remind of us. You have to look at him. Okay. Now the last picture.
Adesso passiamo.
Io chiedo la pausa per non iniziare.
Ah, sì.
Vai la chetichetta.
Guarda la chemichetta.
Facciamo una pausa?
Sì.
2 minuti.
Vediamo voi.
Questo è per...
Cioè, niente,
Ah,
Prego, ci fa entrare la candidata. Scusi. Okay, so we can go ahead with today's dissertation. So we have now Sara Cella discussing with Professor Patrizia Rovere Querini and Dr. Valentina Canti a dissertation with the title of The Beneficial Effects of Therapy on Obstetrical Outcomes and Placenta Cystology in Patients with Antiphospholipid Antibody Syndrome in a Single Italian Reference Center. So Professor Rovere Querini would start by introducing the candidate and the topic of the discussion.
Yes, I don't see the candidate. The candidate. Okay.
Morning.
Morning.
Yes, are you there? You hear me?
Can you hear us?
Yes, I can.
Okay, great. So now Sarah will show us some data on the histological features of the placenta of patients with antiphospholipid syndrome treated as the gold standard. Because now we have some situations of pregnancy loss in which we have the diagnosis and we have also a therapy that is a standard therapy. The outcome of our therapies is an improve compared with the past, but it's not perfect. And so we are we have started this study to better, to deeply understand what is happening in our patients. So please,
yes,
you can start.
Can you see the presentation?
Yes.
Perfect. Thank you for the introduction. As my supervisor said, today I'm going to talk about patients affected by antiphospholipid antibody syndrome. So let's start with a brief introduction on the syndrome. It's an autoimmune condition which can be diagnosed when both serological and clinical criteria are met. It can be primary or secondary to other autoimmune diseases such as systemic lupus erythematosus, and the patient must result positive to at least one antiphospholipid antibody among lupus anticoagulant, anticardiolipin antibody, or beta-2 glycoprotein 1. These antibodies must be tested twice in a period of at least 12 weeks. Moreover, based on the clinical presentation that the patient has, we can have the thromboembolic form if the patient presents with thrombotic events, or obstetric form if the patient presents with obstetric complications. We mainly focused on the obstetric form of antiphospholipid antibody syndrome, and our patients presented with a history of unexplained miscarriage after the 10th gestational week, or premature birth, which was often associated to intrauterine growth restriction, or again, 3 or more abortions which must be consecutive and before the 10th gestational week. For what concerns the therapy, the guidelines state to give a concomitant therapy based on low-dose aspirin, which can be started either preconception or at positive fetal heartbeat, and low molecular weight heparin, which should be started at positive fetal heartbeat. The target organ of the obstetric form of antiphospholipid antibody syndrome is the placenta. The placenta derives from the outer cell layer of the morula, which is formed by trophoblast cells. These cells start proliferating in the initial phases and eventually attach at the level of the endometrium in a site known as the decidua, which is depicted here in pink. Trophoblasts then continue to proliferate and give rise to branch structures known as villi, which are here in light blue, which are covered by syncytial trophoblasts and give rise to vascular syncytial membranes, which are fundamental for the maternal-fetal exchange. In between the villi structures, there is the intervillous space where the maternal blood coming from the spiral arteries, which are here in red, are reversed. However, there is one more type of trophoblast, which is the extravillous one, that migrates towards the decidua
and it is important for the invasion of the decidua and remodeling of the spiral arteries. In fact, in the early phases of pregnancies, the extravillous trophoblasts plug the spiral arteries in order to reduce the reactive oxygen species reaching the fetus, while later in gestation, they remodel the spiral arteries to decrease the resistance and increase the conduction, and therefore also the amount of blood flow reaching the fetus. If the patient is affected by antiphospholipid antibody syndromes, some pathological events occur. In fact, antiphospholipid antibody binds the level of the trophoblasts and lead to their apoptosis, as you can see from the picture on the above on the right. The apoptosis of the trophoblasts lead to the release of syncytial knots, which is known as debris, and a decrease in vascular syncytial membranes, which, as we've seen before, are fundamental for the maternal-fetal exchange. Moreover, the extravillous trophoblasts are also affected. Therefore, you have a decrease in placentation and ineffective placentations, and eventually development of intrauterine growth restriction and preeclampsia. The last player of this pathogenic process is the complement, which deposits at the level of the decidua and gives rise to inflammatory processes. In the literature, the histopathological lesions at the level of the placenta are described as heterogeneous due to the different pathological events occurring simultaneously at the level of the placenta. However, the 5 most common pathological lesions detected at the level of the placenta are infarction, which is diffused and caused by spiral artery occlusion, decreased remodeling of the spiral arteries. In fact, in the picture, you can see that the wall of the artery is still very thick, and therefore this increases the resistance and decreases the blood flow to the fetus. Inflammation of the decidua caused by complement deposition, and increase in syncytial knots and decrease of vascular syncytial membranes caused by trophoblast death. At the San Raffaele Hospital, we conducted a study on 115 pregnancies from 81 women who were followed at the Pregnancy at Risk Clinic from 2010 and 2019. We included in our study also women who experienced 2 or more abortions, because lately more and more studies have decreased the cutoff of repetitive abortions to 2. However, the guidelines state that there should be at least 3 or more consecutive abortions in order to diagnose antiphospholipid antibody syndrome. Moreover, we included also patients who have a slight positivity to antiphospholipid antibodies, and then we conducted a histopathological examination on 21 of these placentas. The patients came to the hospital for the ordinary gynecological visits, and moreover, once a month, they came to a multidisciplinary team clinic based on a rheumatologist and a gynecologist who would check the activity of the underlying autoimmune condition and would titrate the therapy accordingly. The dosage of antiphospholipid antibodies was performed once preconception and then once during the pregnancy, and complement dosage instead was performed every trimester. We stratified the patients according to the primary form and the secondary form. 77% of them were affected by the primary form of antiphospholipid antibody syndrome, while 23% with the secondary form. For what concerns the antibodies, anticardiolipin antibody was the most commonly detected among the 2 groups, slightly more positive in the primary group, while lupus anticoagulant was more commonly found in the secondary group. Instead, for beta-2 glycoprotein 1, the incidence was similar among the 2 groups. Antiphosphatidylserine proton 1 antibody is a new unconventional antibody which has been tested only lately, and that's why we have only 40 samples of this antibody. And also, this antibody resulted more positive in the secondary group. Our patients were affected by some comorbidities such as hypertension and thyroiditis, and some presented with thrombotic events. In fact, in almost 1/3 of the cases, the obstetric form can overlap with the thromboembolic form, and patients can manifest with thrombotic events. The patients came to our clinic with a history of recurrent abortions and early abortions, which were more commonly seen in the primary group, while late abortion and late complications were more commonly seen in the secondary group. Overall, the obstetric complication rate in this case was more commonly detected in the primary group due to the high incidence of early abortions. We then treated the patients with low-dose aspirin, and 82% of them with a combination of low-dose aspirin and low molecular weight heparin. Furthermore, 16% of them were treated with hydroxychloroquine, which is normally given to patients who are refractory to therapy or who are affected by the secondary form. Moreover, low-dose aspirin and low molecular weight heparin not only have shown to have anticoagulant effects, but also anti-inflammatory ones. After the therapy, the outcome improved considerably. In fact, the rate of early abortion in the primary group decreased from 67% to 16%, and in the secondary group from 37% to 12%. Instead, the late abortions decreased from 33% to 2% in the primary groups, and from 19% to 8% in the secondary group. Also, the other late complications have shown to have the same trend, except for preterm delivery, which remained almost constant also in the secondary group. The weight of the newborn and the placenta weight have shown to be much decreased in the secondary group, together with the gestational week of delivery, which occurred earlier again in the secondary group. In this case, the obstetric complications were more commonly detected in the secondary group. For what concerns the histopathological lesions, we didn't see any significant difference in terms of quantity among the two groups, but we definitely have detected a significant decrease of these lesions compared to the literature. Such a wide range of the incidence of pathological lesions in the literature is because some papers have described the incidence in patients who were treated, some others in patients who were not treated. However, we can say that our incidence was almost 2/3 inferior compared to the one of the literature. And we have to specify that in a placenta of a woman who gives birth to a normal baby without any types of complication and at term, there are still some pathological lesions at the level of the placenta. Another interesting finding was the correlation between antiphosphatidylserine prothrombin antibodies and infarction. In fact, in patients who resulted positive to this antibody, the rate of infarction was significantly higher. Moreover, in two patients who were affected by hypertension, we detected the presence of inflammation of the decidua. However, the sample size was quite small, therefore we cannot be sure that there is a correlation between the two, but it was still an interesting finding. For what concerns the other histopathological lesions, we detected an increase in incidence of these lesions in patients who were affected by intrauterine growth restriction and preterm delivery. To conclude, we saw that our outcomes were very good and comparable to the ones of the literature. Therefore, therapy plays definitely an important role. However, as we said before, more and more papers and studies have decreased the cutoff of recurrent abortions to 2, and we would suggest to do this as well to decrease the psychological stress of the patient. Moreover, secondary antiphospholipid antibody syndrome has shown to have a worse outcome, and this can be partially explained by the underlying autoimmune condition, which often manifests with obstetric complications, such in case of systemic lupus erythematosus. Finally, we detected a significant decrease in histopathological lesions in patients who were treated. However, we have not reached our goal yet. In fact, in the future, more therapies and therapeutical regimen may help us in decreasing even more the incidence of these lesions. Thank you for the attention.
Thank you very much, Sara. This was a very nice piece of data. So Professor Rovere Querini would start the discussion.
Yes, congratulations for the results and we are conducting
Can you hear?
No, I cannot hear very well.
Possiamo spostare questo, no?
For the results of the work you have conducted, linking the clinical result and the histopathological data. Can we speculate something about new therapy, new target therapy, in order to further increase the outcome, mostly in secondary antiphospholipid syndrome, and to have a better outcome also in the histology of the placenta?
Yes, definitely. So target therapy has taken more and more attention in the last years. And for example, eculizumab, which is a monoclonal antibody, has shown to inhibit the complement cascade, more particularly at the level of C5 conversion into C5b, and this decreases the production of tissue factor and neutrophil activation and the inflammation in general. This monoclonal antibody has not been used yet in the primary form of antiphospholipid antibody syndrome, but it has been used in refractory cases or, as you said, in the secondary types. But we have seen in some experiments that complement deficient mice have shown to have a dramatic decrease in terms of pathological outcomes, both in the thromboembolic form and in the obstetric form. Therefore, this may be definitely a therapy to look for.
Any other question? So it seems not, so thank you very much.
Thank you.
Back later on.
Perfect. Thank you.
Okay.
Thank you.
Thank you. So we move on to the last dissertation today. We have now Maddalena Lancieri.
Buongiorno.
Can you hear me? Can I have the starter?
Yeah.
Thank you. So, can you hear me now? Better?
Yes, I can hear you.
Very good. So we have the last dissertation. Can you wait a second? I have to introduce you. You are destroying all my formulas. So we have Maddalena Lancieri now, who is going to discuss a thesis entitled Adherence to Colchicine and Response to Treatment in a Multicenter Familial Mediterranean Fever Cohort. The supervisor is Professor Angelo Manfredi, and the assistant supervisor who is connected as well is Dr. Marco Gattorno. I ask Professor Manfredi to start to introduce the candidate and as well as the topic of the discussion.
Sure. So FMF is a very mysterious disease, but in the last decade we have learned some more about the pathogenesis of the disease. But still, it is the prototype of the autoinflammatory condition. Still, we lack information on patients. And Maddalena had the opportunity to be supervised in the study by Marco Gattorno, who is a recognized opinion leader in the field. And they've done an incredible job in tracking what is the real life and especially the treatment of the patient, what they are actually taking. And the results are quite unexpected and I think are very important. So I would ask Maddalena to start with the presentation.
Okay, thank you very much for the introduction. and to the Commission. So this is our work on familiar Mediterranean fever. And just briefly, familiar Mediterranean fever is a genetic illness with some constant, repetitive, and distinctive characteristic. Indeed, when it was firstly described as a clinical entity, it was called benign paroxysmal peritonitis. So a disease, an episodic disease with an early onset in childhood, presenting with systemic inflammation, so 3 days long high-grade fevers and fever-free intervals. The episodes are usually accompanied by polyserositis, mainly peritonitis and pleuritis, and articular inflammation. It is also associated with an increase in acute phase proteins, and for this reason, unfortunately, it is not completely benign in that over time, amyloid A can accumulate and cause potentially lethal amyloidosis. Another interesting finding of this unusual paroxysmal syndrome was discovering that it was caused by a previously uncharted pathogenetic process, which is autoinflammation. In autoinflammatory diseases, as opposed to autoimmunity, the innate immune system is deranging, and the clinical presentation, which appears periodically over the year, is the result of a massive sterile flux of granulocytes into serosal membranes, joints, and skin. And the causal mutation in FMF is a mutation of pyrine, which is a component of the inflammasome and is coded by the MEF gene. Luckily, it was discovered that colchicine, a plant-derived alkaloid and a very old, the oldest drug actually still used today, can safely and effectively reduce the disease attacks and the risk of amyloidosis. It works by blocking the microtubules elongation, so it prevents the rearrangement of the cytoskeleton, it prevents the secretion of vesicles, cytokines, chemokines, and therefore it inhibits neutrophil migration and activation. Moreover, recently it was found that its success in treating FMF may be due to a specific action that it has on the pyrine inflammasome, because it is thought to activate ROA, which is a phosphorylase that inhibits pyrine inflammasome. Still, about 5% of patients experience resistance and require second-line anti-L1 agents. The causes for this resistance are not completely understood. For sure, there is a high penetrance mutation that are one of the mechanisms. However, clinically, it's still a challenge to predict which patient will be resistant to treatment. And to further complicate this picture, all the given definition of resistance have had some pitfalls, especially in defining those patients in which colchicine can reduce but not abate disease attacks. However, recently, a consensus of experts utilizing the Delphi system proposed some criteria on resistance, and we analyzed them through our work. So in this framework, we performed our study to understand the state of art of colchicine treatment and response in a multi-center familiar cohort of FMF. So our aims were to have a demographical and clinical characterization of a mixed population of adult and pediatric patients and a longitudinal cohort of Italian FMF patients, and to examine colchicine efficacy in abating disease attacks, to analyze the effect of colchicine dose adjustments on the clinical outcome, and to evaluate the quality of life and compliance of patients. And we did so by having, in January 2020, 425 patients enrolled in the Eurofever registry from 13 different Italian centers. This registry was born in 2009 as a cross-sectional registry, and then it became in 2018 a longitudinal registry. Then we analyzed the data we had, and we supplemented with a patient hand-in self-completed questionnaire on the quality of life and compliance. Out of the 425 patients we had at the beginning, 84 were excluded because of incompleteness of information, and the longitudinal part of the study was performed only on those patients with at least one follow-up visit. So 262 patients, of which only 236 actually received the colchicine, and out of these 236, 14 also received anti-L1 drugs because they were considered resistant by the local physician. So these are the results from the cross-sectional study. So 341 patients with the median age of onset of 5 years of age, and more specifically about 3 in the pediatric patient and about 12 in the adult patient, and the median age of diagnosis of about 5 and 27 respectively. And this is because adults experience a much longer diagnostic delay compared to pediatric patient. For what concerns the clinical presentation, pediatric patient had more episodes per year than adults, and the symptoms accompanying fever were the one we expected more or less, with the highest prevalent symptom being abdominal pain. The longitudinal part of the study instead was focused on the patient with at least one follow-up visit, and we analyzed the response to colchicine in terms of persisting disease activity. So we classified the patient according to 4 categories of response: no persisting episodes, less than 1 episode per month, 1 or more persisting disease attack per month, and according to the recent consensus statement on resistance, this would be the one considered truly resistant, and those with some persisting disease activity but unknown frequency. And we performed the same kind of study also according to age group, so less than 5, 5 to 10, 10 to 18, and more than 18. So in adults, we found the highest percentage of complete responders. However, if you focus on the 5 to 10 years of age, the complete responders were only 35%, and roughly 15% would be considered resistant to treatment. However, prior to defining a patient resistant to treatment, it is necessary to give him the maximal tolerated dose. And what is usually done in clinical practice is to give a starting dosage, and here I have reported the starting dosage according to the LR 2016 guideline at the bottom of the slide, and to adjust the starting dosage according to the clinical manifestation. So if the patient is still presenting episodes, colchicine has to be augmented. Obviously, on the contrary, if the patient is intolerant to the drug, another alternative has to be sought for. And this is a box plot depicting the mean colchicine dosage according to age and response. There is no significant association between the dosage and the response. And the mean dosages at all age group were actually quite low, and quite close to the starting dosage. So we wanted to see how many patients were actually still receiving a starting dosage or less, and which were the clinical response. As we expected, the percentage of patients still receiving a starting dosage was quite high. And what was striking to find, though, was that the disease activity in this patient was actually still quite high, because in between 14% and 26%, according to the age group, these patients were still having disease attacks despite being treated with the starting dose. And this means that these patients are underdosed. For what concerns the result from the first questionnaire on compliance, obviously compliance is inversely correlated to disease activity, and we found complete responders only among optimal patients with optimal compliance, basically, so taking more than 90% of prescriptions, whereas a dramatic drop in complete responders is observed also in those with the good compliance, so taking between 50 and 90% of the prescription. And finally, the questionnaire on quality of life clearly shows that the increasing the number of episodes, the more the limitation in daily activity, the more the chronic pain, and the more the forced absenteeism. However, I think it's important to notice that about 20% of patients with no persisting disease activity still has chronic pain or fatigue, and about 1/3 of patients with mild disease activity still have a lowering of their quality of life due to the disease. So in summary, we have seen that there is quite a high tolerance toward the persistency of disease activity. And for a disease such as FMF, in which we have possible lethal consequences, but a solid and effective treatment, to have such a high rate of patients still experiencing the disease attack is something almost unacceptable. In fact, we found 46% of FMF patients still displaying disease activity despite treatment, and an optimal colchicine dosage that is probably never achieved in a good proportion of patients, because about 20% of patients of all age group were not given dose adjustment despite the persisting disease activity. And in only 14 patients out of the total, a second-line anti-L1 agent was attempted. And in addition to possible lethal consequences, also in those patients with mild disease activity, so less than 1 episode per month, 1/3 reported to have actually limitation in daily activity or chronic pain and fatigue. So it is a disease that really impacts quality of life. So our findings suggest that further studies addressing FMF patient management and colchicine resistant must be performed, and possibly focusing on the pharmacokinetics of colchicine and the dosages, aiming to find a universal definition that leaves no one behind, and that also comprises the patient's self-perceived well-being and the quality of life. So thank you for your attention, and thank you to my supervisor, Dr. Manfredi, and my assistant supervisor, Dr. Gattorno, and also to San Raffaele Gaslini that hosted me for many months in my career. Thank you.
Thank you very much. Thank you very much, Maddalena. This was really good work and good presentation. I think that Professor Manfredi and Dr. Gattorno will start the discussion now.
Actually, I would ask to Marco Gattorno to start with the questions, since he is directly in charge of this project.
Yeah, oh, okay. Thank you. I hope you can hear me.
Yes.
Okay. First of all, I would like to congratulate with Maddalena. She did a fantastic job. It was a great honor and pleasure to have her in our institute for a few months, and she performed very well in this study. And that is rather important, in my opinion, because we have 2 different drugs for FMF. One very cheap, that we have to use better, that is colchicine, and one very expensive. You know that there is the monoclonal antibodies for anti-L1 that is very effective but very expensive. So this balance between resistance and let's say the right dose is very important also for the payers. So this is a very relevant topic in my opinion. Maddalena, do you think that after these data and this experience, does the real colchicine resistance? So are the patient really resistant, or there is something different?
So there may be a percentage of patients which is truly resistant, in that it cannot tolerate a dose that could stop the colchicine dose that could stop the attacks, meaning not a toxic dose, because before reaching a toxic dose it really takes a lot of drug, but still there may be some patients that are especially sensible to the drug, and so they may not tolerate a dose that can actually achieve the suppression of episodes. However, colchicine seems to be effective. We have seen them like in clinical practice. We have seen that colchicine is actually quite effective, and this data suggested that actually there is an underdosage in general. So it's difficult to give a true definition of resistance actually before having a true study on the pharmacokinetics of colchicine and the optimal dosages.
Yeah. Yes.
Okay. Any other question from the Commission? Comments? So if not, thank you very much once again. You have now the candidates should disconnect, because we need to discuss your grades. Thank you.
Thank you.
Mi dice lei quando possiamo Possiamo richiamare, possiamo stare seduti, questo è l'unico vantaggio del collegamento virtuale. Okay. Sara and Maddalena, can you hear me?
Yes.
Okay. So, first of all, congratulations. You did very well. And now the formal part. I declare that these graduates have fulfilled all the requirements for the master's degree with the following comprehensive final grades. Sara Cella, 110 out of 110, plus honors and special mention. And Maddalena Lancieri, 110 out of 110, plus honors and special mention. So, by virtue of the authority vested in me by the Italian law, I confer the master's degree in medicine and surgery upon the following candidates, Sara Cella and Maddalena Lancieri. Congratulations.
Thank you.
So, as you have seen, it was a pretty fast discussion because you did pretty well over the course of your studies across the 6 years, as well as today with your dissertations. So there was a complete unanimity and very fast unanimity through the Commission to grant you with the maximum of the possible grades. And so we wish you all the best for the near future when you start to work finally after so many years. And I don't know where you are, but I guess that you decided not to come here because you are very close to the sea. There is a big store in Milano, and there is a clinics close to here. So this is my sad life. I will go back to clinics. I guess you will go to the sea, right?
It's raining today, though.
Okay. So congratulations again.
Thank you.
Bravi.
Grazie. Arrivederci.
Arrivederci a tutti, grazie.
Grazie.